Welcome to another episode of On Target Conversations, a series about non-small cell lung cancer. My name is Rasheda Persinger, and I am currently the medical oncology lead nurse practitioner at the Johns Hopkins Sidney Kimmel Cancer Center at Sibley Memorial Hospital, and I will be your host for this series. Joining me today is Beth Sandy, a thoracic medical oncology nurse practitioner at the Abramson Cancer Center at the University of Pennsylvania. Thank you for joining me.
Thank you.
Before we get started, I should note that this is a promotional program supported by AstraZeneca. It is intended to provide educational information on the management of patients with resectable non-small cell lung cancer. We are speaking to you on behalf of AstraZeneca and have received compensation, but the dialogue is based on our personal clinical experience. Today, we will be discussing the unmet needs of patients with resectable non-small cell lung cancer, the importance of a multidisciplinary approach, and the role of nursing professionals in the management of these patients. While the majority of patients with non-small cell lung cancer present with advanced disease, about 30% are diagnosed with resectable disease. Beth, please tell us about these patients and how they present in your practice.
Many patients with stage 1B to 3A non-small cell lung cancer are considered to have resectable disease with curative intent as a goal of treatment. Early stage cases are often asymptomatic and present either on screening CTs or most often as incidental findings of chest imaging for other reasons, for example, knee surgery.
You bring up a very good point. Surgical resection is the standard of care for patients with stage 1B through 3A non-small cell lung cancer, with some patients needing adjuvant treatment. Unfortunately, rates of disease recurrence or death after surgery have been high. For example, in a pooled analysis of 5 randomized trials evaluating patients treated with or without adjuvant chemotherapy, overall rates of recurrence or death following surgical resection for stage 1B, 2, and 3 non-small cell lung cancer were 45%, 62%, and 76% respectively. What can you tell us about the outcomes for your patients? What challenges remain and how do you discuss recurrence with them?
Yes, these figures are a good reflection of our practice. I use the term curative intent, not cure, with patients at the beginning. These patients are likely to experience recurrence even when the cancer is resected in the early stages, unfortunately. And at that point, when the cancer recurs, it is generally metastatic, is considered to be incurable, and usually requires systemic therapy. If the cancer recurs and is metastatic, I explain that now the goal of therapy is to prolong survival. You need to offer them hope, These patients are going through a lot of emotional distress.
Absolutely, Beth. In our practice, we usually explain to patients that 1, even after surgical resection, micrometastases, which are undetected by standard staging methods, may remain. This can increase the likelihood of disease recurrence. 2, common sites of metastatic recurrence in patients with non-small cell lung cancer following surgical resection include the lung, brain, bone, and liver. 3, as you mentioned, initial metastatic recurrence following surgical resection occurs in multiple sites in approximately 40% of patients. So with this, you have to understand that for these patients, every scan can be extremely stressful. As we continue to follow our patients, we have to balance the need for hopefulness with being realistic and transparent at the same time.
CNS metastases deserve special consideration. The CNS is a sanctuary site for metastases, where the blood-brain barrier may protect tumors from systemic treatment. EGFR mutations have been suggested to be associated with subsequent brain metastases in patients with stage 1 to 3 non-small cell lung cancer.
It is interesting that you mention EGFR mutation status as an underlying key driver of disease. What do we know regarding the prevalence of these mutations across the different stages of disease?
EGFR mutation prevalence appears to be consistent across all stages of non-small cell lung cancer, with average rates in adenocarcinoma between 18 and 26%. In addition, as we know with metastatic disease, EGFR mutations may be present regardless of race, gender, or smoking history. Let's talk about how we can best help our patients with resectable EGFR mutation positive non-small cell lung cancer. I would think the first step is to identify them. In fact, the NCCN guidelines recommend molecular testing for EGFR mutations on surgical tissue or diagnostic biopsy samples in patients with stage 1B to 3A non-small cell lung cancer. Among the different specialties, medical oncologists are most likely to order the test. Can you describe the testing process in your practice, including who orders the molecular tests and the role of advanced practice providers?
Absolutely, Beth. In our practice, patients with stage 1B to 3A non-small cell lung cancer are referred to us from the thoracic surgeon. It is in the initial consultation with the oncologist after surgery that the discussion takes place regarding adjuvant treatment options, including obtaining EGFR testing. My role in this process, as with the oncologist and our nurse navigator, is to continue to follow up on the results of testing to avoid unnecessary delays.
So that's interesting. At my institution, we are getting most of our resected patients before they're tested. Let's say 2 or 3 weeks after surgery, a stage 2 patient is seen by medical oncology to initiate the chemotherapy process. That's when we order his or her test. But if our nurse navigator knows about the case ahead of time, she will send the order for the molecular test for us in advance. There is enough tissue from the resection and enough time because of the 12 weeks of chemotherapy. We see some stage 1B patients. The surgeon will usually talk to the patients first, and some stage 1B and even stage 1A come to see us for a consult. Our nurse navigator is very good about offering patients with early stage disease the opportunity to see medical oncology and then arranging it.
This is a good segue to the importance of working with a multidisciplinary team, especially communicating with a surgeon's office, to ensure that every eligible patient is referred to a medical oncologist as early as possible.
We may also help in the logistics of EGFR testing, such as which specimen to use and when to test, which may mean more coordination across the multidisciplinary team. There are, in fact, several possibilities for molecular testing. If available, biopsies can be tested prior to surgery. The surgical specimen from the resected tumors should be tested for EGFR mutations. Standardized molecular testing processes may help to ensure consistent testing implementation.
These are great points, Beth. Reflexive molecular testing for early-stage non-small cell lung cancer is not done routinely in our institution and therefore is requested after the patient is seen in consult. Molecular testing for EGFR mutations in patients with previously resected non-small cell lung cancer provides an additional opportunity to help identify patients and determine appropriate adjuvant treatment options.
So our nurse navigator is in touch with the thoracic surgeon, the medical oncologist, and the pulmonary specialist and helps communicate with the surgeons outside of Penn. We also have a dedicated tissue navigator. The multidisciplinary tumor board here is also very effective in discussing resectable non-small cell lung cancer cases before surgery. However, not all cases of resectable non-small cell lung cancer are brought to the tumor board. We know that after resection, many of these patients should be seen by the medical oncologist for treatment and should receive molecular testing. There is no controversy. However, since EGFR mutation testing in resectable non-small cell lung cancer was added to the guidelines in 2020, this may be particularly important to reinforce.
I completely agree, Beth. In community practice where the surgeon is in a different location and there is no navigator, things are much more complex. Access to a tumor board would provide a platform to discuss resectable non-small cell lung cancer cases regarding testing for EGFR mutations and appropriate adjuvant treatment decisions. I think education, coordination, and timely communication across the multidisciplinary team is essential for optimal care. And this is true not just for patients who may have EGFR mutations. In general, we know patients with lung cancer who are managed using a multidisciplinary approach are more likely to receive guideline-recommended treatment and have improved outcomes. Beth, thank you again for joining me today. Do you have any last comments before we close?
Thank you, Rasheda. We recognize that we should support navigation of all patients with lung cancer through the system and ensure they are referred to all appropriate cancer specialists who contribute to a multidisciplinary approach. This will help ensure molecular testing and appropriate treatment options since there are recommendations in place for molecular testing in resectable non-small cell lung cancer as well as for metastatic disease.
Certainly. Absolutely, Beth. We should educate both our colleagues on the multidisciplinary team and our patients about the importance of EGFR mutation testing in resectable non-small cell lung cancer. And molecular testing results can help inform adjuvant treatment decisions. I would like to thank our audience for listening and hope you will tune in again soon. To listen to more episodes of On Target Conversations, a series about non-small cell lung cancer, please visit the web address as it appears on your screen.